Good day and welcome to Learning Thursdays. I am Dave Kruder with the OASAS Learning and Development Unit and will be your host for today's presentation. The presentation today is part of our series on professional ethics and is titled Year of Ethics, Self-Disclosure. The presenters are Tricia Allen, who is counsel in the OASAS Legal Counsel's Office, and Maria Passeri, who is the director of the OASAS Bureau of Addiction Treatment Centers. Learning Thursdays are offered to addiction professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the educational and professional development of the prevention, treatment, and recovery workforce. We do this by offering monthly presentations that are relevant to today's substance use disorder service professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. At this time, I will turn it over to today's presenters. Welcome, Trish and Maria.
Thank you, Dave.
Thank you.
So we'd like to welcome you to today's Learning Thursday, Year of Ethics, Self-Disclosure. This is our 5th edition of this initiative. And today we are going to, hopefully, by presenting this to you, achieve the following goals. Our hope is that you will understand the ethical aspects of self-disclosure in the counseling relationship and recognize how self-disclosure of someone's personal recovery can impact the successful delivery of counseling and, in certain cases, hinder. And then also understand the clinical implications of self-disclosure and the relevance of self-disclosure when you're working with specific unique populations, such as LGBTQ populations. We also hope to provide guidance on self-disclosure for peer specialists, especially given the fact that peer specialists have as a core of their function the use of self-disclosure to build a rapport with patients. And then we're also hoping that you will understand the roles and responsibilities of disclosure on social media and its impact on past and present patients and colleagues. Obviously, we know social media is a huge part of life now and is increasingly becoming more and more prevalent. So we felt that that was truly quite a timely topic to cover with you. So let's talk a little bit about what self-disclosure is. Generally, it's when you're speaking with someone or communicating with them anyway, verbally, non-verbally, and you're showing or sharing information, details about yourself with someone other than yourself. So in the therapeutic environment, it's a little different. Self-disclosure in the therapeutic environment is more of an intentional technique that you're using when you're trying to communicate with a service recipient or a patient, where you're sharing information about your personal life that happens outside of the counseling relationship, but you're sharing it with your patient during the counseling relationship. So the thought is, and I think this has been around since maybe the 60s, maybe before that, is by sharing with the client information about your personal life, you are kind of modeling certain behaviors or information that they can identify with. And it's a way to establish trust and get them to be a little bit more okay with talking to you, less guarded. It was thought to be an opportunity to get the patient to be a little more forthcoming with you. So what I will say, and I want to just differentiate between a boundary issue as opposed to a boundary violation, because I'm going to say that self-disclosure can be considered a boundary issue. So when you're speaking with a client and you're divulging personal details about your life, that could implicate boundary violations depending on how severe it is, but it absolutely is a boundary issue. It could be indicative of crossing a very bright line of the difference between the role as a counselor and the role as an individual. So when we talk about appropriate and clinically driven disclosure, there are certain things that you are going to disclose as a matter of course. Just by function of the fact that you are in the room and you are breathing, you are sharing some information unintentionally that is going to be a boundary crossing, but is not necessarily a boundary violation. But where the disclosure is inappropriate, if perhaps there's a picture on a wall which identifies you as a parent, you're there with your children, and the individual that you're working with perhaps has had a negative experience with their parent, it's possible that that could impact the professional relationship that you have with them, or it could have a negative impact. Another circumstance that I could think of, perhaps you are going through a difficult time, a divorce, a death in the family, an illness, something like that, and you disclose that during the treatment setting. You know, that while relevant in your life could have a hindering impact on the client. And sometimes we'll hear, you know, somebody will say, oh, that person's having a bad day because this is going on in their life. And that could, while it may seem relevant at the time, it could have a negative impact on the relationship between the client and the counselor. So what is it that a counselor or that a patient should know about a counselor or an addiction professional? What's your background? You know, what school did you go to? What trainings do you have? Is there anything specific about your education that makes you particularly relevant to assisting someone in this field? For CASEX, we have a specific credential. So if you're working as an addiction counselor, knowing that you have a CASEX is absolutely relevant when working with a client. It's totally relevant for them to ask that. Another thing is, how many years have you been in the field? Maybe you just started, maybe you've been in it for 30 years. You could be an individual who, in addition to a CASEX, has an LCSW or an LMSW or another mental health license that the individual would want to know about, or, you know, might be interested in understanding how that's going to impact their treatment when they're working with you. Another item that they might want to know about is your therapeutic orientation. So are you a behavioralist versus a Gestalt theory person? And that orientation that you bring to how you work with that client, it's entirely relevant for them to know. Some items of, some materials that are going to be disclosed just by virtue of yourself being in the room. So your name, it's totally relevant for your client to know your name so that they know who they're talking to. Another thing that might come up is your speech. So obviously people from Brooklyn or the Bronx have a very distinct accent as opposed to someone from the Midwest. It's very different. So people are going to be able to pick up where you're from based on the way you talk. They might be able to know or may guess at the type of family you come from. If you're a very loud, boisterous individual, they may assume that you are from, you know, a very loud, boisterous culture. Another inevitable disclosure or inadvertent disclosure is, say if you wear a religious symbol as a necklace or a bracelet, you may have pictures up on your wall of family outings, you know, people who are special in your life. So, you know, even just sitting in your office, your clients are going to be able to glean additional information from you. They may be able to look on your bookshelves and see that you've got books about specific behavioralist theories, or, you know, maybe there's motivational books that you have available. If you're like me, you have a diploma or certificate hanging on the wall to, you know, identify that you've completed this version of education. And then another, the last item that I'm going to cover is information that could be on Facebook or Twitter, or I don't actually know some of the newer social media. I shudder to think how many of them there are now. So that information that you have put out there on social media that you've made public, individuals, if they so choose, can go look you up on Facebook and see, you know, what you've said in the past, who you're friends with, where you came from, where you live, where you went to school, when you were born. You know, there's quite a lot of information available on social media now. When we're talking about self-disclosure, there's a couple of relevant ethical principles that you need to consider when you're thinking about having any type of self-disclosure circumstances between yourself and a client. So the first is beneficence, and that is doing good for the patient. The second is non-malfeasance, and that is doing no harm. I sometimes equate this to the Hippocratic Oath for some reason. So, the third is to remember the fiduciary relationship between the clinician and the patient. So, at the end of the day, the interest and the welfare of the patient is always the primary concern, as well as respecting the dignity of the patient. That is absolutely the principal ethical guideline among or above all others, is respecting the individual that you're working with. So when I discuss that, I'm actually going to point out a couple of related boundary violations. So remember earlier I mentioned boundary crossing. So that's just recognizing that there is a bright line between the patient and the counselor. And there may be circumstances where what you say or what you do is not, goes over that bright line. But the degree to which it goes over is when it becomes a boundary violation. So if we're talking about respect for the dignity of the patient, one violation that would absolutely be contrary to respecting the dignity of the patient would be to take advantage of the patient. So respecting the dignity of a patient could include speaking to them in a kind or appropriate manner, and then maybe knowing that that patient is very unable to say any type of, they're a yes person, they can't say no. So if you know that about a patient and you kind of exploit that, that is something that would definitely be a violation. Another ethical principle to consider is the respect for a patient's healthy goals. So having a patient set a goal to, I'm going to go with something very simple. Maybe they've never done laundry before and they want to learn how to do laundry and they want to do it well. There is some discussion about whether or not you're supposed to sort out all of the different colors into different piles, but generally speaking, having them learn that's a healthy goal, and helping them to do that and facilitate that is great. But if you insert your own goals into the circumstances, well, I'm not going to have them learn to do laundry, I'm going to have them learn how to do my laundry, or some other idea that maybe is more to the benefit of the counselor than the client, that becomes a boundary violation. When we talk about autonomy, that's the individual having the ability to make their own decisions, and the counselor's willingness to allow them, obviously within reason and not in any way that's going to cause bodily harm, to make their own decisions, as opposed to maybe influencing them to follow a certain path or take a certain medical intervention or something that maybe they're not comfortable with, but you've talked them into it, obviously, again, within reason. If we talk about the fiduciary relationship, there's also the boundary violation would be an exploitative relationship. So if you are working with a patient and you end up using them for your own gratification, or you become involved with a patient because in a personal relationship with the patient, at that point you've now gone from being somebody who is in a fiduciary relationship with your patient and promoting altruism to instead using the patient for your own gain. Another circumstance where this could come up is if you were to abuse a patient by taking money from them, then you've kind of crossed from having a fiduciary relationship with the patient to exploiting that relationship. So with that, I think I'm going to turn it over to Maria for her to cover more of the therapeutic and clinical discussion.
Good afternoon. One thing that I would like to say before I even get started with the slides is this particular topic was established a lot of robust conversation with counselors when we did it at the addiction treatment centers. So I'm encouraging you to take a look at this particular PowerPoint and consider doing a discussion with staff because it brought up a lot of feelings. A lot of counselors like to self-disclose in terms of how they do their job, and this gives you some guidance so that you're avoiding any kind of boundary violation and then get involvement with the Justice Center. Okay, so with that, I'd like to talk about establishing the Therapeutic Alliance. The Therapeutic Alliance is a critical aspect of providing care to our patients. It's an outcome that we're looking to establish in providing substance use treatment to our patients. So it's about creating a collaboration and a partnership, and we do that not necessarily through self-disclosure, but we do that through possessing the knowledge of addiction, the lifestyles of addicts, and taking that information and sharing that with the patient. No matter how expert the counselor is, we have to remember that the patient is the most important person, and the patient is the expert in the relationship. So it's really important to listen, it's important to empathize, and it's also important not to pass judgment in terms of what our patients share with us. So we should be seen as an ally, not the expert, so to speak, in the relationship. And the important part of our interventions in fostering a strong therapeutic alliance is involving the counselor's active listening and those that emphasize collaboration, so that we're not doing it all, the patient's not doing it all, we're working together towards establishing a foundation for recovery. So the question is posed, really, should addiction counselors disclose their recovery? And I like to start with a lot of reasons why we get into counseling. And most people decide to be an addiction counselor because they themselves are in recovery. And their reasonings are pretty clear. Their motives are admirable. They want to help others. It's a good way to give back. It's also part of the 12th step. They're also individuals who are passionate about recovery because they know it's attainable and attainable for others. And they also have experienced treatment, and they sometimes have a desire to do things differently so that they can engage people in recovery because they themselves have experienced relationships that maybe were not necessarily helpful in getting them on their way to a strong recovery. So the good thing about someone who's recovering and a counselor is that they bring passion, energy, and personal experience that can be an asset to the recovery process. So with all of that being said, I ask the question again, should a counselor disclose their recovery in the treatment center? So in most of those cases, the answer is no. Disclosure of recovery can often be a hindrance to the successful delivery of treatment. The drive to become a counselor can be less healthy than by using their profession as a substitute for their own recovery. Also, a reason why it might not be good is that counselors may use helping others to avoid their own intimacy and to avoid looking at their own issues. Also, from a cognitive perspective, counselors are pushed to reflect on the idea that there are many paths to get to recovery and stay in recovery. And so oftentimes they want to push how they recovered versus allowing somebody a possible different path to that recovery. So as a result, what we find in terms of boundary violations with regard to self-disclosure is that counselors can be more heavy-handed and they have a more prescriptive approach. There's the right and the wrong way. And oftentimes that kind of concrete approach to recovery can get conflict. The patient may not want to respond positively, and therefore may end up administratively discharging from the program instead of possibly using whatever behavior occurred as the teachable moment. There are many different reasons why self-disclosure is a problem. And many of you who've watched it in action can say sometimes counselors will use disclosure as a shortcut to establishing and maintaining a therapeutic relationship. We find that it's very easy to tell your story. So if you're going into group and you don't have a plan, utilizing your story is a way to quickly do a group, and it doesn't require much preparation. So it's really important to know that if you're going to be utilizing evidence-based practices such as motivational interviewing, cognitive behavioral interventions, then those are things that require planning and process, and again, active listening to what the patient is saying and moving it through that particular practice. Also, what can happen is there's various forms of transference and countertransference that arise that are not necessarily identified and addressed that impact the patient's recovery. So, and we all know that it takes a lot of supervision to kind of unfold transference and countertransference on what we're doing that's triggering the patients, on how we respond to patients as a result of our own life issues. Those are things that are not easily sorted out. So by virtue of just telling the story, it can be very difficult and pose problems that aren't necessarily visible at that time. The other thing that can happen is that it may present an ethical boundary, including role reversal. So now the patient is seeing the counselor as needing their help versus the reason why they came into treatment to take care of themselves. And so that is really important. And oftentimes we see that when counselors have problems or life situations that are very hard to separate, home versus work life. Also, it could be life events, divorces, significant losses, and or sometimes counselors are unwell and unfit for duty. And so the supervision process, again, is very, very important to help discern whether or not someone is well enough to be a counselor, to be able to put everything aside in their personal life and then be there for that person who's in recovery.
One question that I'd love to ask, and I'd love to unpack it a little bit more. So when we talk about self-disclosure, it's entirely possible, or it could entirely be possible, that when an individual is disclosing and providing this information to a counselor, that when the counselor responds back, yeah, I went through that, and starts trading war stories with them, does it impact the way the client feels about what they've gone through, or almost minimize and kind of make it feel less legitimate for them to feel conflicted about what's happened with them? How does it impact the client on an emotional level at times when that happens?
Something like that has to be done very delicately, if that's the way it's going. But for the most part, what happens is when you begin to trade war stories, there is no therapeutic value to that. And the patient may feel like, well, I guess I'm not going to talk about me because they're going to continue to talk about themselves. And oftentimes when I've received complaints from patients, they will say is, I'm only hearing about their recovery. I'm not finding out what I need to do for my recovery. We always have life experiences that are very different from our patients. And so we need to give them an opportunity to tell their story. If they're looking for validation, sometimes sharing a little bit is helpful. However, for the most part, you can have an effective relationship with your patient without sharing any part of your recovery. Your recovery will shine based on who you are as a person in terms of your integrity and respect and dignity for the patient, they will see a healthy recovery if you embody that in your day-to-day presentation.
Thank you.
Don't need a story.
Yes.
There are other problems that happen with regard to self-disclosure, and that is that it can compromise the professional relationship. So the counselor views, the patient views the counselor as a friend versus the professional. Also, it moves the focus away from the client, as we just talked about with Tricia in terms of trading stories. Then the focus becomes about you as a counselor and not as a patient. Also, the client may feel burdened and may hold back or censor information because they're picking up other cues by your story. And so maybe there's something that you shared that now they're not going to share with you based on what they know about you. And clients may also feel that the counselor's too involved, so that they dominate the counseling relationship, and that pushes them away as well. And they also can feel pressure, since the counselor is disclosing, they're going to feel pressure to disclose when maybe they're not ready to disclose. And there are some things that take time for our patients to disclose. Sometimes the traumatic events in their lives are times when they have to be safe and ready to disclose that, and will not disclose just because you're disclosing as the counselor. There was another body of literature that I thought was very interesting in terms of clinical considerations with self-disclosure. And the first one being personality disorders. And we all know how difficult it is in treating personality disorders. There are special therapeutic interventions that we use. The dialectical behavioral therapy is one practice that we use with individuals with personality disorders. But if we use self-disclosure with those individuals with personality disorders, we find that these are individuals who already have trouble with boundaries. They often will establish the good person and the bad person in the counseling team. So they have confusion with the structure of the relationship. So there is a lot of evidence in the literature that tells us that personality disorders is something that we want to avoid using self-disclosure. And our patients who have personality disorders also are unable to integrate the counselor's self-disclosure in a way that's healthful and helpful. In working with those individuals who are LGBTQ, there isn't a whole lot of literature out on this population, but the literature that I did find was very, very interesting and kind of was true to my experiences in the field. And I think that this is an area that probably needs a lot more literature and research. But what I did find, what I thought was very interesting and that we wanted to share with you today. First of all, with working with this population, there is a high therapeutic value in the counselor's self-disclosure of sexual orientation. Several studies suggested that clients prefer and seek counselors with the same sexual orientation, which apparently increases trust and affiliation and a therapeutic alliance. And you will see that one of the things we work very hard on in all of our programs is to be welcoming for this population. And this population does seek to find individuals and counselors who will share their sexual orientation in the relationship. Also, with this population, I thought it was interesting that they're also often brought up in environments where their sexual orientation leaves them isolated and misunderstood. And that's a significant difference than our other populations, because oftentimes individuals haven't shared with their immediate family, they haven't shared with a lot of people, and haven't come out yet. So they are very isolated, and they often stay away from treatment because they don't want to be abused or ridiculed in any way. And they often feel that they're misunderstood by others. So they lack role models, that their identity is normative. And so that's why they seek programs that are welcoming for this population. Some positives with self-disclosure for this population: it can offer, as I said before, role modeling and reduce stigma. If they feel more comfortable and relaxed, they may be able to share more about their experiences and how their experiences have impacted their recovery. Also, studies have shown that the decision for a counselor to disclose is an important factor for LGBT clients that can affect whether or not they're going to seek treatment. So that, in an effect of getting somebody in the front door, is very, very important. So whether you're a program that specializes with this population or not, understanding the cultural competency in working with this population is really important, because we want people to have access to treatment, feel comfortable in treatment, and also establishing a therapeutic alliance with the counselor. As with everything, though, revealing one's sexual orientation may not be right in every circumstance. Premature disclosure can cause confusion and disrupt the therapeutic alliance. So again, timing is something that is very important as a counselor in everything that we do. And so even in this case where there's a lot of positive information about self-disclosure, we still need to be judicious about it and think about why we're disclosing and the importance of our disclosure in terms of it benefiting the patient. Peers are coming into our facilities little by little, and having them come into our facilities, having us understand what role do they play. Many times they're put in roles as an assistant counselor, but really there is a specialized role for the peer. And so it's important that we understand that, and there is a lot of literature out on that. Also, one area that OASAS is developing every day, Susan Brandow is working with peers and establishing criteria and guidelines with peers. So I suggest she also is someone to contact in finding out more information about how peers can impact the recovery process. So some information about peers. Their job is really to draw upon lived experiences to share empathy, insights, and skills. They serve as role models for the patients, and their goal is to instill hope, engage in services, help access supports in the community. So they have not only a role within the treatment setting, they have a role outside of that as well.
And I would point out one of the realms that we're seeing a lot of movement with the peers. I think we're seeing this more and more with the 24/7 open access centers and the emergency rooms. When individuals are coming in who've been reversed on naloxone or have come in with some other SUD-related issue, or maybe even a chronic medical condition that's been exacerbated by the chronic medical condition that is the SUD, substance use disorder. Yeah. We see a lot of interest and a lot of uptick in the use of peers in that environment as a person who can come in to a location and speak with the patient and talk about, you know, hey, I was you, I was there, I've been there, let me help you, let me guide you to where you need to go. You know, maybe there's a treatment program here, there's a recovery center there, there's, you know, I can help you understand if your insurance is giving a problem, hey, I've been through that, I can help with that. You know, they definitely are becoming a pretty prevalent role in our field to help people when they come in and are in crisis or are in some sort of circumstance where they need somebody who's been through it and who can help them find the right place to go.
Thank you. So peers and self-disclosure. Self-disclosure is a key to the peer specialist role. They also need to be comfortable with discussing their story and be willing to disclose to peers. One of the things that needs to be set in terms of boundaries is peer specialists should not be expected to disclose detailed information to their coworkers. There are a set of guidelines, practice guidelines for peers, and I wanted to share a few of them with you that I think are relevant to this particular topic. So the first one is they're sharing hope. Peer supporters tell strategic stories of their personal recovery in relation to current struggles faced by those who are being supported. Peer supporters are models of recovery behaviors at work and act as ambassadors of recovery in all aspects of their work. And also, peer supporters help others in reframing life challenges as opportunities for personal growth. So that's really important as well. All under hope. The fourth practice is listen with emotional sensitivity. So peer supporters understand that even though they may share life experiences, the range of responses may vary considerably. So as we have talked about, there are many different paths of recovery. There are many different experiences in addiction. So it is important to listen with emotional sensitivity. And so that's what we had on peers. I'm going to move to social media now, and I will tell you that we have had our share of Justice Center violations with regard to social media. So hopefully we can provide you some guidance here in terms of how that impacts the treatment setting. Some things you need to remember is online postings, blogs, chats, or profiles may be viewed by current and past patients. Anyone can search a name. So as we talked about way in the beginning of this presentation, we talked about some inevitable disclosures, and your name is one of them. So in their curiosity to find out about you, they can look you up on various sites. The information on these sites, in some form, stay on forever. So it's really important that you take a look at blocking different aspects of your social media from only the listed friends that you have. When a service provider creates clear disclosure guidelines, the use of the internet can inadvertently create a whole new set of ethical problems, and that's what we realized. Because many patients want to stay in touch with you as a counselor, keep you in the loop about their recovery, and so oftentimes we find counselors friending them on Facebook. Mm-hmm. And so, again, establishing some clear guidelines about what you can and cannot do, because again, you're changing the role of the counselor from counselor to friend. So we tried to give you some questions to ask yourself before posting. First one being, what are the pros and cons of posting information? because a lot more information gets disclosed with the various postings and how they spread to other friends and shared and move through different systems. It's also asking yourself the possibility that the client will be negatively affected. Is it something that you're doing in your social life? Some crazy picture of yourself at a moment where you and your friends are laughing, but it isn't necessarily what you want to portray as your professional view. Also, how will the disclosure affect your relationship with your clients? And one of the things we try to remember is that a client is always, we want them always to feel comfortable returning to treatment. We know that relapse is part of the disease. And so if we change our relationship to friend, then we're less likely to be a conduit for that individual to return to treatment when need be. How often, does the disclosure threaten my credibility or undermine the public's trust in the field of addiction counseling? And again, I go back to that picture. And last but not least, am I responsible for the public's trust? And I think that as a counselor at a particular agency, I think that we have some need to be professional, to be available for individuals who are in need of help and families who are in need of help as well. One of the things that we recently had an issue with, or remembered that it was in a private chat actually, and so people thought that private chats are private. But one of the things people have done is taken a screenshot of the private conversation and then posted it somewhere else. So there are things that you can have in a private conversation with somebody, and then it gets misinterpreted and can be made public by just a snap of the picture. What you should not post is any client information at all. Disparaging comments about colleagues or client groups or even your employer. We've had individuals who have been disciplined for talking bad about their employer on Facebook and other chats. Also, unprofessional media, photographs, videos that undercut your reputation and the reputation of the addiction profession, and comments about one's litigation. So in summary, some degree of self-disclosure is inevitable, but self-disclosure can become boundary violations when they are not made for the benefit of the patient. And that's the biggest question we have to ask ourselves. What's the benefit for the patient? Also, self-disclosures of a personal nature that do not have a clinical purpose, whether requested by the client, may inhibit exploration and or invite other boundary violations. Patients shouldn't know that you're struggling in your marriage. Patients shouldn't know that CPS has contacted you. Whatever kind of difficult or delicate situation that's going on in your life, you should not be sharing with your patient. And I say it almost on every slide, every population that we work with. Supervision is the most important aspect of providing substance use treatment services, including peer support services. So even if self-disclosure, as it is with peer support, a part of their job, they still need supervision to put it in a way that's beneficial to the client and not for their own purposes. Also, establishing appropriate and healthy a therapeutic alliance with the patient provides the best opportunity for providing effective treatment and support services. So I'm hoping that you understand and have some guidance around self-disclosure. There's continued references that we have listed there for you check out and take a look at. And you can always contact us as well. There's our email information. And again, I suggest taking this topic up and putting it into a group discussion or a group supervision with staff in order to get some feedback and answer questions, because when we do this in front of an audience, oftentimes it brings a lot of healthy discussion. So I encourage you to do that. And thank you so much.
Thank you very much.
I'd like to thank Trish and Maria for this beneficial presentation today. At this time, I'd like to remind you that we welcome your feedback. It lets us know if we are meeting the educational goals and expectations of our field. Once you have viewed the presentation in its entirety and completed the quiz, please follow the directions to access the SurveyMonkey and complete the evaluation. Thank you for watching this presentation with us, and enjoy your day.